Good afternoon, everyone. Once again, I do want to thank you so much, all of you, for sticking around. I know how hard it is to stay here after lunch. Listen, you want to be in the conference, you just want to pack your stuff and go. And that's why I really appreciate your presence here. Before I move to my second talk, there were lots of questions sent via WhatsApp and the number regarding my first lecture about NSAIDs. And I'm going to answer 4 questions relatively quick. And what I'm going to do is, if you do have more questions, you can use my Twitter handle, you can email it to me, or maybe even a coffee break after my talk, I can just meet with some of you, and if you have any questions, I'll be more happy to answer them. The first question was, is there any difference between ibuprofen, or let me rephrase it, is ibuprofen really better than ketorolac when it comes to pain management? In reality, yes, it is. There is no difference between 60 milligram of intramuscular ketorolac in 800 of oral ibuprofen. But if you do oral ibuprofen, you avoid painful needle, you avoid pain and injection, and you avoid the side effects that I mentioned earlier, specifically GI upset. There is no difference between 30 milligram of ketorolac given IM, intramuscularly, and 400 milligram of ibuprofen. In the United States, ibuprofen is 10 times cheaper. So no pain and injection, no side effects, and it's very efficacious and it's cheap. Second question was, how about pediatric patients? Are we using analgesic saline dose? In reality, for little babies, we use 10 milligram per kilogram dose for ibuprofen, and I would not exceed 400. And if you get in toddlerhood, and if you get in young adults, its analgesic saline concept still applies. It's 400 per dose up to 3 times per 24 hours. Another question was, in your opinion, in my opinion, what's the optimum duration for the prescription for the patient who suffers from acute painful conditions to go home with? I usually prescribe 3 days worth. No more than 3 days. 5, rarely, if ever. 3 days worth of ibuprofen, 3 days worth of naproxen, 3 days worth of diclofenac, with the premise that you may add something to it, all right, and you're hoping the patient will get better. If acute painful condition persists beyond the 3 days worth of prescriptions, then patients should be reevaluated either in the PMD office or in the emergency department. And the last question was, is there a difference with respect to onset of analgesia between low-dose NSAIDs and high-dose NSAIDs? So the answer is no, there isn't. They all kick in at the same time. The only difference between larger dose, it lasts longer. All right, I hope I answered some of your questions. Once again, I'm going to take the rest of it either on Twitter or offline. All right, let's talk about a path to the PainFreeED. Once again, I recently co-authored this little book. I hope to get royalties, but not just yet. Pain is the most common chief complaints that patients seek care in the emergency department, probably worldwide. 75 to 80% of patients who come to the emergency room have any type of painful conditions, which means it's imperative for us, ED doctors, to be good, to be excellent, to be terrific, to be experts, to be what I like to call EM algiatrists. We are pain specialists, and frankly, we are. And frankly, we're taking care of patients in pain better than anybody else I've known. So we should be all proud of this. I would like to introduce you to a concept that's very dear to me. CERTA stands for channels, enzymes, receptors, targeted analgesia. This concept was born out of 2 things. Out of my personal annoyance with this term multimodal approach that's been abused in the United States. Everybody uses the word multimodal, but the only modality they use is a shot or pill. So this modality does not exist. And a second reason this concept was born is out of necessity, because once again, in the United States, we have a huge opioid epidemic, and this concept actually helps us to use non-opioid analgesics first. CERTA concept stipulates that it allows you to use patient-specific pain syndrome targeted approach by doing following things. You are combining or putting together analgesics of different classes, acting on the different target sites, such as channels, enzymes, or receptors. And that very synergy, that combination, will give you superior analgesia if you compare this combination to single agent. Synergy will allow you to decrease the dose of analgesics. Lesser the dose, less side effects. Pain is the same, but side effects becomes unimaginably lesser because you use a lower dose. Less side effects, better stay in the emergency department, shorter stay in the emergency department, everybody wins. Patients are happy, doctors are happy, and bosses are happy. All right? That's what CERTA does. particularly for United States, by using CERTA, I am utilizing non-opioid analgesics first. And if they fail, I use opioids as a rescue. And I'm trying to do this on every single patient, with few exceptions, of course. Non-opioids first, opioids to the rescue. Let me show in practice how does it work based on evidence. Dr. Philippe Mulligan did a beautiful talk yesterday on renal colic, and I'm just going to reiterate because he covered all the bases. Patient with renal colic, what's the best medication? NSAIDs. And now we all know we're going to be using NSAIDs with analgesic saline. If you give ketorolac, it's going to be 10. If you give diclofenac, it's going to be 50. Nothing beats it. These are COX enzyme inhibitor, enzymes inhibitor. They decrease pain, decrease inflammation, and they reduce urethral spasms. That's how NSAIDs work. Now, and there's no difference between ketorolac or diclofenac and such. There is a data, mostly coming out of Turkey and Iran, that intravenous paracetamol is actually very efficacious when it comes to managing pain of patients with renal colic. I disagree with it fundamentally. I'm not going to much elaborate to it for the sake of time. But there's a data, 8 trials, that compared intravenous paracetamol, 1 gram over 15 minutes, to morphine at 0.1 milligram per kilogram. 5 trials show no difference. 2 trials show that paracetamol did better. 1 trial showed that paracetamol did worse. The major problem with the studies is that morphine is titratable. Paracetamol is not. So that's why basically comparing apples and oranges, or apples and tomatoes, whatever you want to compare it. You cannot compare titratable to non-titratable analgesic and make an assumption that one is better than another. Paracetamol is a weak analgesic, should not be used alone, but you can add paracetamol to NSAIDs. Why? Because paracetamol, when it comes to analgesia, is not a COX-1, COX-2 inhibitor. It actually potentiates vanilloid receptors. It's a completely different ballgame. You can combine this too. And this is your CERTA. All right, we know that NSAIDs work better than paracetamol. Combine this two, pain gets better. Now, we can use lidocaine for a subset of patients who, let's say, fail opioids or they fail NSAIDs, right? 2 randomized trials, 1 case series, cardiac preservative-free lidocaine given at 1.5 milligram per kilogram over 15 minutes seems to be working well. Once again, it's non-titratable, but can be used as a good adjunct. Lidocaine plus ketorolac, lidocaine plus diclofenac, lidocaine plus morphine. It may work. You combining medications, different classes, because what's lidocaine? It's a sodium channel blocking agent. So enzyme inhibitor, vanilloid receptors such as IPAP, and sodium channel blocking agent. This is your CERTA. All right? Desmopressin, synthetic analog of vasopressin, antidiuretic, antispasmodic, and that's how it relieves the pain of renal colic. By itself, it's a really bad medication. It doesn't really work well. If you combine this with NSAIDs, either diclofenac, oral, parenteral, or rectal, works like a charm. 2 medications, different receptors or enzymes, work terrific. And lastly, metamizole, which is not available in the United States, 500 milligram a pop, maybe go to 1 gram. You can combine this with NSAIDs. Why? Because just so happened that metamizole actually is not an NSAID when it comes to analgesia. It potentiates endogenous opioid system and cannabinoid system. You can technically put them together. If you use analgesic saline dose for both, risk of bleeding is going to be negligible. And all of a sudden, we have a variety of medications we can use for renal colic. NSAIDs, lidocaine, intravenous paracetamol, desmopressin, metamizole. So you have 5, 6 analgesics. Combine them. 2, 3 medications together. See what happens. If all fails, you can always use an opioid. All right? Or you can use an opioid and NSAID and then use all the medications I mentioned to you. Patients with acute trauma. I feel like you all agree with me that this is almost inhumane not to give an opioid to this patient. But what if this patient is a recovering opioid addict and he tells you, I don't want an opioid, find something else for me? What if this patient is 85-year-old female with an end-stage COPD on home oxygen, with renal failure, on aspirin, Plavix, and Coumadin? Typical patients in my shop. So you're probably not going to be comfortable giving her NSAIDs and probably not be comfortable giving her opioids whose O2 sat is 90% in the room air. It's just slightly altered, right? So what's there? Well, it just so happens we have a magic of 21st century. Ultrasound-guided regional block has revolutionized the way we practice medicine. And as of right now, 2018 in the States, this is almost standard of care. Anyone who's older than 65 who comes in with a broken hip or fractured femur should be getting ultrasound-guided regional block. What are we using? We're using sodium channel blocking agent, lidocaine, bupivacaine, or chlorprocaine. Ultrasound really changed our analgesic armamentarium. There is a never-ending slew of data that clearly shows for a patient with acute musculoskeletal trauma of upper extremities, ultrasound-guided brachial plexus block, axillary nerve block, forearm blocks, ulnar radial median will give you complete pain relief, total muscle relaxation, and it's so good for fracture, dislocation, subluxations, abscesses, or lacerations. No opioids, no NSAIDs, no sedations. Everybody's happy. Takes about 5 to 7 minutes to do the procedure. Win-win for everyone. Similarly, there's a great deal of data that patients with a lower extremity trauma, fractures, subluxation, abscesses, laceration, will greatly benefit from ultrasound-guided regional block. Femoral nerve block, fascia iliaca compartment nerve block, sciatic nerve block, posterior tibial nerve block, same thing. Total muscle relaxation, complete pain relief, no side effects, if any. This is the way to deal with a musculoskeletal trauma in the 21st century, in 2018, I would say. And if you're like me, if you want to push envelope just a bit further, you have these very patients I mentioned to you earlier, who's 85, she's 92 now. She's not really good as a breather. She's on every single anticoagulant known to humans. She has 4 broken ribs. You give an opioid, she stops breathing, she dies. You give her NSAID, she starts bleeding to her chest cavity, and she's going to die. What's there? Well, there's an ultrasound-guided serratus anterior plane block, safe, effective, knocks off pain from the 3rd, 4th, 5th, 6th, 7th, 8th, and 9 ribs. Gives you anesthesia of the anterolateral chest wall. Nothing gets better. For elderly people, they're not loopy, they're not sedated, they're talking to you, they're sitting, you give them sense of parameter, pain is gone for an average 8 to 10 hours. This is beautiful. And a similar talk, you have a patient who comes in with the abscess of abdominal wall, or they have a big cut across of their abdomen, or they have incarcerated umbilical hernia, and they're in pain. And let's just say for the sake of it, they cannot take opioids, or they cannot tolerate them, or you don't want to give them NSAIDs because they're going to the operating room. So what do? You do ultrasound-guided block, TAP, transversus abdominis plane block, anesthesize anterolateral abdominal wall for about good 10 hours. So all of a sudden, ultrasound changes everything. Okay, you just tell me, you know what, this is a little too much for us. We're not really there yet, or maybe we're too lazy, we don't want to do it. What else is there? There's ketamine. And enough with the fact that you guys are using ketamine, which is fantastic. Just to refresh the memory, same as Felipe did, when we're talking about ketamine, we're talking about analgesic dose ketamine, 0.1 to 0.3 milligram per kilogram, right? Remember, the good thing about ketamine is it does work, but the bad thing is, faster you push, more prominent side effects become. And when it comes to analgesic dose ketamine, we call them psychoperceptual side effects. Patient becomes loopy, they have this out-of-body experience, they are feeling unreality, basically like Alice in Wonderland. In English, we call this, they're tripping. And it's bothersome, and they don't like it. So there's a data that shows that for the short-term analgesia, I would say about 2 hours, low-dose ketamine or sub-dissociative dose ketamine works just as good as morphine. But if you really want to be a astute physician, you can push it to elderly people. Elderly people actually do get pain relief similar to morphine if you give them sub-dissociative dose ketamine at 0.3 milligram per kilogram. But they're all getting loopy. They're all having this out-of-body experience. They don't like it. So this is a take-home message as far as the ketamine goes. Next time you want to use ketamine for pain, 0.1 to 0.2 milligram per kilogram over 30 minutes. Not 10, not 15, 30. I guarantee you, you're going to have a beautiful analgesic response, and you have a significantly decreased rate of these psychoperceptual side effects. This is important. And if, once again, and if you're like me, you want to push the envelope a bit, you can always put the patients on continuous ketamine infusions. You start at 0.15 milligram per kilogram per hour, and you go up by 5 every 30 minutes. It may work for a patient with exacerbation of chronic pains, patient with a sickle cell, which I'm going to talk in a second. Intravenous paracetamol was shown to be effective as adjunct to opioids in managing traumatic pain. And we can probably give 1 dose of methimazole within 2 analgesic ceiling, unless you want to fight with a surgeon or orthopath. And now, once again, all of a sudden, you have this patient who cannot either tolerate or refuse to take opioids or NSAIDs, and you can offer him a block. You can give him ketamine. You can give him single dose of intravenous paracetamol as an adjunct. You give him a little of methimazole. And now you're golden. Instead of 1 or 2 modalities, you got 6. All right? Let's talk about little children. This beautiful 7-year-old, amazingly beautiful girl falls off monkey bar. So she comes to you. She has an obvious deformity. She has a Colles fracture. She's frightened. She's crying. Her parents are as crazy as anybody else. They're ready to stab you with a needle. Please help our daughter. And so what do? All right? You can't get to her to put an IV access yet, but you need to help her. So easiest thing to do is to give her nitrous oxide. Nitrous oxide is a volatile anesthetic that controls the pain by stabilizing brain neurons. It just so happened that nitrous oxide is partial mu receptor agonist. It potentiates endogenous opioid system. You can give yourself good 10 to 15 minutes of a breakthrough pain for this little baby, but 7-year-old. If you combine nitrous oxide with a hematoma block, so you're using sodium channel blocking agents such as lidocaine and bupivacaine as a hematoma block together with nitrous oxide, you'll succeed immensely. And there's a data that clearly showed nitrous oxide plus hematoma block works better and lasts longer than procedural sedation with ketamine and Versed. Gas and block. Everybody's happy. Now, I did my workshop with pediatrics, and I mentioned earlier, we don't have it in the United States, and also you don't have it here in Chile as well, methoxyflurane, another volatile anesthetic. But there is a 50 years worth of experience in New Zealand and Australia that clearly shows if you use this in sub-anesthetic dosages, 3 ml, you can repeat it every 60 minutes, you can get amazing pain relief for pediatric and adult patients who present into the emergency department with acute musculoskeletal trauma. So nitrous oxide or methoxyflurane plus minus hematoma block, everybody's happy. Let's say you don't have any of it, but you do have ketamine. If we can use intranasal mucosal atomization device, if we can help this patient, this 7-year-old beautiful girl, we give her 1 milligram per kilogram of intranasal ketamine up to 3 doses until she calms down. And then we can either put an IV or give a nitrous or give a hematoma block and reduce her fracture. Sub-dissociative ketamine given intranasally at 1 milligram per kilogram works good. And lastly, there is a slowly growing body of literature that you can actually do ultrasound-guided block on pediatric patients. And if you do so, they do better. There was a case series of pediatric patients with a femur fracture, 10 years old, 11, and 12. They did so much better. They had a reduction in opioid consumption. They were better in bed. They were less loopier. And frankly, after surgery, they had an earlier ambulation. Ultrasound-guided regional block for pediatric patient works just as well by using sodium channel blocking agent. And all of a sudden, when this beautiful patient of yours, next time you're going to hit child in distress with acute musculoskeletal trauma, don't wrestle them, don't try to put the IV, calm them down and see what you can have. Use intranasal fentanyl, use intranasal ketamine, use a little bit of nitrous oxide if you can. And if you get to the point you can block them afterwards. And lastly, I want to talk about sickle cell disease, which is not easy. And we had amazing presentation by Dr. Alvarez on acute chest syndrome. It's nearly impossible to imagine managing patients with sickle cell crisis without an opioid, and rightly so. This is one of the entities that you should be giving opioid. Which one and how much, that's a different story. But let's just say you want to give something else instead. Ketamine, as a continuous infusion, start in the emergency department. Start them in ED, send them up for 2-3 days. You will decrease opioid consumption by 50%, and patient will feel so much better. You don't want ketamine? Start them on lidocaine continuous infusion. Sodium channel blocking agent, same thing, 1 to 2.5 mics per kilo per hour. Start them in the ED and take them upstairs. I need one more slide. Okay, and the last thing, which is not ready yet for the prime time, although I strongly believe this is a good analgesic, when it's given in analgesic dose, Precedex, known as dexmedetomidine, which is used widely in ICU for sedation and analgesia. It can be used for patients with sickle cell disease. Same principle. You give 1 mg per kilo loading dose and then start them at 0.5 mg per kilo per hour. And they worked. And then all of a sudden, you have several options for sickle cell disease patients, including opioids. Opioids, ketamine, lidocaine, and Precedex. So this is just a glimpse into what we have available. We can talk more and more and more. But let me summarize this. Once again, we're all fantastic. We're all EM algaiatrists. We take care of patients in pain. And next time when a patient comes in, utilize this concept that I mentioned to you. Combine analgesics of different classes that act on the different target sites, because this combination will give you an ability to use patient-specific, pain syndrome-targeted approach, and you'll succeed immensely. All right? You'll be able to achieve significant analgesia that you wouldn't otherwise do if you use single agent alone. Because ultimate goal for all of us is to make our patients as possible, as pain-free as we can, but most importantly, make them all happy. On this note, this is me again, my email, my Twitter handle, please use it if you have any questions. I really, truly, truly appreciate you guys having me. It's been fantastic. Muchísimas gracias. Thank you so much.